Hello, everyone. Welcome back to classes, as it were. It's Dr. Hessian, and it seems as though we're going to be spending a good amount of time together over this online platform in the next coming weeks so that we can keep ourselves and everyone around us safe in this sort of unprecedented, at least in our lifetime, um, COVID-19 crisis. I hope everyone's holding up. I hope you're all safe and well, and same with all of your loved ones. And I know you're all responsibly practicing excellent social distancing to keep yourself and others and patients out in the communities, all those high risk populations, safe from our germs as well. So let's get comfortable and work on getting through our first lecture together. So today's lecture will be on care of patients receiving radiation therapy. Remember, this is a lecture that got rescheduled or swapped around with one of Professor L's lectures earlier in Unit 4. And so imagine, if you can, in your mind, that we just finished talking about chemo and biotherapies, and we're going to roll right into radiation therapy. So when we talk about the goals that we have when we're providing radiation therapy for patients, the goals of the radiation therapy can vary a bit. Sometimes it's to kill cancer. So we use radiation, particularly in early stage cancers that are very localized, to try and target and kill the cancerous cells in that area. We can use it to contribute to providing disease control, meaning we're trying to keep the disease from progressing. We don't expect that we're going to cure, but we can at least control or try and shrink the area to make it more resectable from a surgical perspective. Or we can use it to relieve symptoms, which, of course, you all know, of course, is a palliative intention. Um, Sometimes certain cancerous masses can be detrimental to surrounding tissues and nerves and areas and cause things like pain, um, trouble breathing, um, and other sort of sequelae that if we can radiate from a palliative nature, we're trying to minimize those symptoms for them. So it's important for us to understand kind of what the goals are. Today, more than half of people with cancer will receive radiation therapy at some point. And just like all of the cancer treatment modalities, we can use radiation alone, or very commonly, it's also used in combination with surgery and/or chemo or biotherapies. We sometimes use it before surgery. We sometimes use it after surgery. These days, they do intraoperative radiation therapy, IORT, which we'll talk about a little bit, particularly with early stage breast cancer patients, and they do lumpectomies and things like that. Sometimes they'll do localized radiation right in the operative room. Um, just to make sure that we've gotten every last cell, because remember, it takes just one cell to travel and metastasize. Again, this is a localized treatment, so we're aiming at one particular area. And so the side effects that we see in the tissues, kind of physically in the body tissues, tend to be right in the area of where the radiation is aiming. That's not to say we don't have some systemic side effects that we'll talk about, but when we're thinking about what proactively we might expect for side effects, thinking about where the radiation is going will help direct us as to what to expect. Um, there are both short and long term effects and sequelae from radiation, so we'll talk about those. Okay, how does radiation therapy work? So, high energy radiation sources are used, and the goal is that we're targeting a specific tissue area. We're trying to damage the DNA of the cells, the cancer cells, that makes it impossible for them to continue replicating. Because remember, the problem with the underlying issue with cancer is an abnormal overgrowth of the cells, right? So we need to stop that growth. And so with the medicines we talked about, chemo and biotherapies, we target different parts of the cell growth replication cycles and growth cycles. And radiation therapy tries to damage the DNA of the cells to interrupt that process as well. There are different ways we can deliver radiation. We can use external beam therapy, so pointing to the patient from an external source and targeting a particular area. We can do internal implantation radiation therapy, so implants. There are seeds and other types of implants that we'll talk about briefly in certain types of cancer. Or you can do whole body or whole brain and things like that, more systemic radiation therapies. Just some terminology we use when we talk about radiation dosing. Um, Exposure um, is a term that means the amount of radiation that's delivered to a tissue. Okay. So how much is delivered? How much are we exposing them to? The radiation dose is the amount of radiation we expect will be absorbed by that tissue. Okay. So how much actually gets absorbed into the tissue is affected by things like how intense the radiation is, how long or how many sessions of radiation we're giving them, and also how close the radiation source is. So, are we targeting from outside, or is this an implanted source that's right at the area of concern that is going to be giving a more intense dosing right to that tissue area, maybe for a few days duration? It depends on the situation, but there are differences in how we can deliver radiation when we're looking for different, I guess, potencies. How much we want to use sort of depends on the particular patient scenario. So, how big is the tumor? Where is the tumor? Um, what other structures is it close to? So, by location, we also have to consider. Remember, I said we can get side effects for any surrounding tissue areas that are near where we're radiating. When we're looking at radiating a particular spot in the tissue, we need to be mindful of what other body structures are near there, and what sort of risk levels we can or cannot take for damaging those body structures. Um, Sensitivity to radiation. So, certain tissues are more sensitive to radiation than others. And we just know that from research. Um, I imagine some of it has to do with the regenerative nature of particular body tissues. Um, but for example, the liver tissue, which we know liver can regenerate, is more sensitive to radiation than, say, breast tissue is. So that's important to know when they're considering dosings. Okay, external beam therapy. So these are the folks that go to radiation 5 days a week for a short period of time and get radiated to a particular area that has been predetermined and set up ahead of time with the radiation therapists and the radiation oncologists. From outside the patient. So the patient is not radioactive. When we're using external beam therapy, they are radiated at a particular point on their body from an external beam, and then when it's done, it's done. They are not radioactive, and so there is no hazard to anyone else around them. That's a really important point to understand, both from a patient education perspective and a nursing care planning perspective. Okay, this is the most commonly utilized delivery method for radiation. This is what you hear about the most. Um, Again, they go in 5 days a week to the radiation therapy clinic, and they usually have a set time and day. And it doesn't take long. When it's their turn, they're in and out in like 10, 15 minutes tops from start to finish. They go in, they get undressed, they go into um, the LINAC or the linear accelerator. I provided a picture there just so you can picture what it is. And they lay on the table in whatever positioning has been predetermined so that the area we're aiming at is accessible. And they get their external sort of laser beam of therapy. Um, they are continuing to work on additional techniques for external radiation therapy. I mentioned intraoperative earlier on. They're using that a lot in breast therapy. Uh, Intensity modulated. So they're basically trying to get more accurate with where the beams are going, um, which helps us try to cut back on the damage that we can do to surrounding tissues. Before patients start external beam radiation therapy, I mentioned they have kind of a planning visit that's done in advance, and that is called a simulation. And so the scans and images that have been ordered and taken and reviewed by the healthcare providers, the radiation oncologists, and the radiation therapists are used to define exactly where the tumor is, the patient goes in and they get marked for precision so that they are always aiming at the exact right place. Um, they sometimes have little small ink tattoos or markings on them, like an X marks the spot sort of a thing, so that every day when they go in, it's easy for them to make sure they're aiming where they're supposed to be aiming with the radiation. Position fixing devices can be custom made. So, say somebody has a particular spot in the head that they need to radiate, they might have sort of a face mask that is custom made for them that holds them in a specific position to ensure that it's the same positioning every treatment and they always hit the right spot. Okay. Hmm. I'm going to have to get back to brachytherapy because I'm not sure, quite honestly, why it's not showing up. So, my apologies, and I will get back to that. Okay. Side effects of radiation therapy. So, I mentioned there are localized side effects. So, in the area of where we are radiating, okay, there's something called radiation dermatitis, and that is, of course, a skin inflammation issue. And this happens pretty commonly with our radiation patients. Ranges from a red kind of a rash, erythema rashiness, to what is called desquamation, which means that actually the skin itself is sort of peeling away in layers. It can be wet or dry, sort of in nature. You can imagine the severity of that really can be quite distressing for patients, depending on how bad it gets. Um, it's sort of based on the dosing that they get for radiation and how many doses and how long they're getting the radiation. It also is potentiated by patients that are on concurrent chemo or biotherapy. So, patients that get both chemo and radiation tend to have more profound side effects in general of both. They sort of potentiate each other. Um, there can be sort of permanent skin changes, hair loss if they're aiming in that area of the body, really hair loss in any area that might have hair when they're radiating through certain areas of the skin. And then location specific risks. So if they're radiating a mass in somebody's lungs, we have a risk for pneumonitis, so an inflammation in the lungs, right? If their radiation is a head and neck cancer patient, there is a risk for changes in the dentition. If they're radiating somewhere in the abdomen or in the GI tract, there are risks for changes in their bowel patterns. So, being mindful of where is being radiated and kind of what structurally is around those areas will help us be good detectives when we're seeking out kind of likely side effects and symptoms we should be watching for. These are some examples of radiation dermatitis, sort of there on the left, a little bit worse in the gentleman in the middle, and that's desquamation on the right. So aside from localized side effects, we also, I mentioned, do often get these systemic side effects in patients who are receiving radiation therapy ongoing. They too can get that sort of strange alteration in taste that can happen with our chemotherapy and biotherapy patients, particularly our chemo patients, because those taste buds are sensitive. Um, Fatigue is pretty well guaranteed with radiation therapy and or chemo or biotherapy, like we talked about. Patients can expect to be fatigued. This is an assault on the body, so you can imagine that that takes a lot of energy from the body to deal with. And then we do see some bone marrow suppression as sort of a systemic side effect of radiation. Particularly, we watch platelet counts in patients with radiation. They will hold radiation doses for patients that have low platelet counts. So when we talk about nursing interventions, um, there's sort of some different realms that we need to pay attention to, right? So I had mentioned skincare. We want to teach patients to use really good moisturizing, infection prevention if they do have any rashes or breaks in the skin. So keeping those areas clean. So gentle cleansers and gentle drying and covering certainly if they're open skin areas and weeping at all, how to dress those areas safely. We teach them about sun protection. Their skin will be more sensitive to the sun than somebody who's not undergoing radiation therapy. So, teaching them to utilize their sunscreen, but also even more to use wear sort of long sleeved, light layers of clothing, hats, keeping their skin from direct sunlight as much as they can is a good idea. Nutritional supports is something we do a lot with folks with radiation, depending on where they are radiating. Of course, our head and neck patients, for example, those folks struggle significantly nutritionally during radiation and chemotherapy process. They usually have a combination of both at the same time. These folks often even have feeding tubes placed proactively, sort of in the beginning, prophylactically, I guess. They have G tubes placed because we expect that at some point they will not be able to take in adequate nutrition by mouth because they get that radiation dermatitis sort of all down through their oral cavity and their throat and their esophagus. So it becomes really painful for them to eat and drink. But some supports we can do for people, of course, nutritional supplements, whether that's by mouth or at some point via G tube. We do a lot of teaching about that. Saliva stimulants, there are products that help promote more saliva production in the mouth, and that can help folks that are battling sort of really terrible dry mouth side effects. Medicated mouthwashes, much like we talked about in chemo, when folks get that stomatitis, mucositis, when we have some medicated mouthwashes that we can prescribe for people that can sort of numb those areas and treat some of the rashiness issues. We use those for radiation folks as well. Antiemetics, folks can get some nausea from radiation at times, so we do make sure that they have um, adequate management of nausea if need be with antiemetic medications, and antidiarrheals if we're having any sort of diarrhea side effects from the treatments, say to the bowel area. Coping support. So we do a lot of patient education about what to expect. Um, you can imagine that for patients, this is pretty scary to be radiated by this beam, and they don't understand the different types of radiation and whether they are or are not um, radioactive per se, safe to their other family members. What side effects might they expect, excuse me, and how might they support themselves in sort of minimizing the risk of those side effects. Um, as always, cancer therapy and having cancer at all is distressing to our patients. So we do a lot of coping support, a lot of encouragement. Um, these sorts of things are really distressing to them. They have side effects that happen during radiation, and then we'll get to some longer term side effects as well. And so they can get really frustrated if they finish radiation and 4 weeks later they don't feel perfect. Um, it takes time for the body to work these things through. We do a lot of interdisciplinary care for patients receiving radiation therapy. Dietitians always checking in, watching for weight loss, asking how they're doing eating and drinking. Social work, transportation to a facility 5 days a week can be tricky for some people. So a lot of times it's transportation coordination. Maybe they are missing a lot of work and they need help with medical leave paperwork, or financial supports that might be available in the community, and then support groups for other patients that are going through same things. Some more nursing interventions. We talk about fatigue management. We're teaching them about sleep hygiene. So destimulating, turning off screens, dimming lights, um, meditation, mindfulness, imagery, anything we can do to help people sort of get good sleep habits, and how to manage the need for some extra sleep due to the fatigue from treatments without totally upending somebody's sort of normal day and night sleep cycles. Gentle exercise, again, we do encourage that for sort of that healthy physical fatigue that does help people rest better when it's time to do so. Um, and then for appetite, educating patients about small, frequent meals instead of trying to sit for really large meals. And again, the treatment of sort of mouth side effects, thrush, stomatitis, those sort of things we had spoken about in chemobio. Okay, guys, sorry for that little pause. And the screen should have changed a little bit. We should be back to brachytherapy. Um, I think the updated presentation format is actually on the computer at the college, which I have chosen not to go and expose myself to get. In any case, let's get back to brachytherapy. So, jumping back, we had spoken about external beam therapy. And now I want to talk about brachytherapy. So, brachytherapy is a term for internal radiotherapy or close or short therapy. So, basically, a radiation source is placed or implanted in continuous contact with the tumor tissue for a specific amount of time. And remember, I said we talk about the intensity of dosing. One of the things that makes it more intense is the proximity of the source of radiation. And so when we implant a radiation source directly into the tissue of concern, we get a higher dosing of that radiation to the tumor cells itself and less risk for accidental sort of surrounding dosages to the healthy tissues in the area. So there are a couple of different upsides here of the brachytherapy. It can be given, it can be implanted in solid form, or it can be soluble, meaning sort of a liquid to a specific area. It can be given, we can give brachytherapy in oral or IV routes, but it depends on where we're trying to get it to go. Okay. Because the radiation source is inside of the patient and it's staying there, the patient is radioactive while that is implanted. So a patient does emit radiation if they have an implanted radiation source that's staying in their body. That's really important to understand. Okay. Forgive me, I'm going to have to scroll here instead of flipping. Here we go. Okay. So there's sort of two different classes when we think about how what sort of level of precautions we need to maintain around these patients that have implanted radiation. There's sort of two different groups. There are unsealed isotopes and there are solid or sealed isotopes. So unsealed isotopes means that the radiation source that's inside of the body can enter into the body fluids and so can travel around the body and thus will be present in body waste products. So think urine, sweat, stool, saliva, okay? Once the therapy is completely eliminated, patient and waste products will no longer be contaminated. And how long it takes for that to be true depends on sort of the particular isotope they use and the half-life of that isotope. But what's important for us to know is if they have unsealed brachytherapy in their body, we need to assume that all of their body waste products are radioactive and are hazardous, and we need to maintain appropriate precautions when caring for these patients, okay? Solid or sealed isotopes are implanted right at the tumor, and they may be temporary, meaning a certain amount of days, or they might be permanent and they sort of wear out with time. But they are sealed, and so their effects do not enter body fluids, and so they don't come out of body waste products. The patient still emits radiation, but there's not a particular concern of the body fluids. So that radiation risk is really more to do with the proximity that you or others are to where the radiation implant is in a patient's body. Okay. This is one fairly common use for implanted radiation. We talk about seeds, which they use in prostate cancer therapy. You can see as compared to a penny how tiny these little seeds are. And you can see on the imaging to the right where it looks like in the center is sort of lit up by stars. Those are implanted radiation seeds in somebody's prostate. So these folks that have implanted radiation therapy um, do emit some radiation. And a lot of these folks are going to be um, admitted for periods of time. Okay, this is where you would be caring for these folks in facilities. Okay, so they obviously would have a private room that would be labeled for radioactive materials and precautions. Okay. Any staff that's caring for these patients would wear a dosimeter and a lead apron. So a dosimeter basically keeps track of how much radiation exposure you have had throughout the day in your shift. Um, your job is to figure out how to group care and maintain positioning for yourself as far from the radiation source as possible during that care. So you don't want to be spending a lot of time per shift in close proximity to these patients. And so you have to be really mindful about organizing your care, getting yourself all the things you need to do. You want to try and get them done the one time you're in the room, that sort of a thing. If somebody has implanted seeds, say in their prostate or in the GU system, you would want to be closer towards the head of the bed more of the time to assess your patient and speak with them and care for them to try and distance yourself as much as you sort of logistically can from the implanted radiation source in the body. Visitors will have limitations as to how long they're allowed to visit, and they're advised to maintain distance from the patient, even within the room. No pregnant visitors or staff should be in the room. Any dislodged implants should be handled per protocols of the facilities, but typically it's a long-handled forceps that go direct that are used to pick up the source and directly put it into a lead container. So these are particular precautions that are required for radioactive materials. If you're caring for these patients, you would of course have particular training and competencies about how to handle these scenarios, but it's possible that you would go to take care of this patient and you move the blanket and there's this, tiny little radioactive seed that has dislodged from the patient. It's in the bed. You should not be handling that with your hands, even your gloves. That should be used, the forceps and that sort of a thing. So you would have particular training around that. Linens are maintained in separate disposal bins in the room. They are on strict precautions from everyone else. Okay. Let's see. We talked about localized side effects of radiation therapy. We talked about dermatitis and desquamation. We talked about systemic risks associated with radiation. Okay. Late effects to normal tissue. Like I had mentioned, these radiation side effects, some of them happen right during the courses of radiation and for a short time sort of thereafter until the radiation totally leaves the body. Um, but there are late effects, sort of down the road effects that can happen to patients that have undergone radiation therapy. These can occur months or even years after treatment, and these don't go away. These are permanent side effects um, of the radiation therapy that they have received. As you can imagine, any insult repeatedly to certain tissue areas can cause scarring and fibrosis, so scar tissue. So say someone had radiation for uterine cancer. Remember I said if they're doing external beam radiation, surrounding structures can also be damaged. They've gotten better at pinpointing these beams of radiation, but it's not a perfect science and they still can cause damage to surrounding structures. So if someone had uterine radiation, they could, a couple of years down the road, have a buildup of scar tissue and present with a colon obstruction, a bowel obstruction, because of these adhesions and scar tissues that have built up years later after radiation in the abdominal or uterine and lower GI tract area. Um, Sometimes we see increased risk of cardiovascular disease, okay, because we have more sclerosis of certain vessels that got damaged from radiation to certain areas in the body. And so we have sclerosis and buildup and plaques and narrowing of these vessels, you can have more pronounced cardiovascular disease down the road. We talked about nursing interventions. We talked about that. Okay. I wanted to talk about complementary and alternative medicine. I think I touched on it briefly, sort of in chemo and bio, but there's an opportunity here to discuss it a little bit more. Um, there's a growing body of research around all sorts of cancer care that show that integrating complementary and alternative medicine techniques into patients' care plans, in addition to our Western medicine techniques that we're using, can really promote a better sort of experience of therapies and treatments and healing for patients. And more cancer programs are integrating these sorts of resources in their care planning. I know in my clinic, we have a massage therapist who comes a few days a week and provides chair massage or foot massage for patients while they're receiving treatment. But they also get um, sort of um, gift cards or what's the word, vouchers for massages that they can have outside of clinic time every couple of weeks at a local facility with the same massage therapist who is trained in caring for cancer patients. We have an acupuncture resource. They have an acupuncture group a couple days a week, a couple evenings a week that patients can sign up to be a part of during active treatment. As acupuncture has been shown to decrease things like nausea, peripheral neuropathy, anxiety, pain. And I have care for these patients who give me firsthand accounts of how they had been getting cancer therapies for a long time. And then when acupuncture started to be offered to them and they started participating in that, they found a real difference in their side effect profile. So, um, the research supports it, and just anecdotally, my patients really do as well. So, we're integrating a lot more sources. We should be asking our patients also what sort of modalities they might be utilizing outside of what we're offering to them. Um, do not think that these patients are not online constantly looking for resources or things they can try to get rid of their cancer. They are. And it's unreasonable of us to ask them totally not to. What we do ask is that they share with us um, kind of real time wise what they're considering about doing for interventions or treatments or therapies, herbals, dietary changes, restrictions, things like that. There's a lot of research and data that patients will find about those sort of things online, but we need to be clear about what sort of things they're using and making sure that those sort of, say, herbal supplements don't. Um, minimize the effectiveness of the Western modality treatments that we're also using. So we need to have these conversations with our patients, and we need to be open and non judgmental about them and really work with them to come up with a plan of care that seems reasonable to everyone involved. Remember, patient centered care. Some other examples, I mentioned acupuncture, homeopathy, and Chinese medicine. Again, some of those are herbal sort of things, and we need to be careful as far as interactions with other medications. Um, Tai Chi and yoga can be really helpful for our patients. Reiki, in addition to tissue massage, can also be very helpful. We've been trying to find a new Reiki practitioner for our clinic because they really did find that helpful to patients. And again, research sort of supports its effectiveness in helping their experience through treatments. Chiropractic, sometimes if patients are having changes in their body functions, they might be holding their body differently. They can have more sort of musculoskeletal issues. We have an art therapist at our clinic. It mentions their art and music therapy, and she comes and works with patients, and she is a licensed art therapist, and she's an artist herself, a painter, and she works with patients while they're getting treatment. But she also has art therapy groups that meet in the evening sometimes, and it's really cool. All the patients' artwork gets displayed around the clinic. Support groups, of course, we do a lot of connecting patients with support group resources for whatever they may be going through. And patient families and caregivers as well, by the way, we have to remember that they are hugely affected by cancer care. And so we want to connect them with support resources as well. Vegetarianism, or there's other sort of dietary changes that people will read about. And there's nothing wrong with people making those choices. We just have to make sure that they are well educated in how to meet the nutritional needs their body has during this time within whatever parameters they're willing to work in. Um, vitamin supplements and herbals, like I said, we really need to make sure that interaction wise with other medications, it's not a problem. Okay. So, gosh, lectures go a little bit faster when it's just me chatting and nobody is able to ask questions. And that will be a challenge of this format. So, what I'm going to do and what we as a team have talked about doing is I'm going to create a discussion forum, sort of a discussion thread, and I'll title it to go along with this particular lecture. And I'd like you to post any questions that you've had during this lecture that I did not answer for you in this discussion thread. And what I'll do is have it open for, say, 24 hours after the lecture opens, which would be kind of the scheduled time the lecture was meant to be presented. 24 hours from there, I'll have this discussion thread open, and I encourage you to post your questions to me, kind of about content or things you might have asked in class for clarifications. And then I will post sort of a summary response, taking into account all those class questions, and get that out to you all sort of within another 24 hours from there. Okay, so we're going to work on that, and I will work on prepping my next lecture to get that posted. Again, hope you're well. I welcome feedback about how this is going for you as far as um, being able to understand what I'm saying and see the screen and all those sorts of things. Please do speak up if there's any challenges. I'm always available over email. Okay.